We welcome you all to Talk the Talk. My name is Janine Steen.
And I'm Toni-Ann Antoniato.
A Masters of Myofunctional Therapy, interview physicians and dentists on Long Island so you can learn how their services can benefit your child's speech and language development and complement the therapy that they are receiving.
Welcome to this episode of Talk the Talk. Today we are joined by Dr. Richard Baxter, a board-certified pediatric dentist. Dr. Baxter is a nationally recognized speaker on tongue ties. He's the founder and owner of Alabama Tongue Tie Center, the instructor of the comprehensive course Tongue Tied Academy, and the author of the best-selling book, Tongue Tied: How a Tiny String Under the Tongue Impacts Nursing, Speech, Feeding, and more. Welcome, Dr. Baxter. We're so happy and so honored to have you with us today.
Thank you so much for having me. I'm excited to be here.
Oh, it's a pleasure. It's a pleasure. So before we go into our questions, we just wanted to give our viewers and our audience a little understanding about tongue ties. And tongue ties, as you know, and you're going to explain, relates to tethered oral tissues and how that can impact both speech and feeding. We're going to focus today much of our time in discussing the correlation between a short lingual frenum and how that actually has an impact and can cause issues with regards to sleep disturbance, especially in children. Yep. So can you explain? Oh, of course. Can you explain to us the correlation between a general correlation between lingual frenums and sleep disturbances in children?
Yeah, of course. So it actually starts in utero, right? So tongue tie and airway issues, it's like peanut butter and jelly. They're so interwoven, it's hard to separate them. But a lot of people don't even realize that. So starting in utero, the tongue should be resting up on the palate. And so if it's not, then it won't get that. It's like a scaffolding. I think Barry Raphael kind of coined that term. He's up near you guys. But anyway, he's an orthodontist. But if the tongue is not up in the palate molding it, in utero, it already starts forming a more high arch palate or V-shaped palate, which then makes less room for the airway, the sinuses, the nose, because the floor of the nasal cavity is the palate. And so what happens is the tongue is in a lower position because it's held down by a tether, a string, or it's restricted of some kind. Baby comes out, now they're having trouble nursing. And so they switch to a bottle, which bottle feeding, again, encourages that high arch palate versus breastfeeding. So I used to think like the breast milk is what's important, which really it is. I mean, it's much better than formula, of course. We don't like breast milk or breastfeed shame moms, of course. But if you can, obviously breast milk is better. Getting that breast tissue, though, helps to mold the palate. So I didn't realize that. I thought, okay, breast milk, either way, if it's a bottle or breast, doesn't make a difference. No, the studies are breastfeeding versus bottle feeding. You have less risk of braces, all these other benefits in the airway lifelong. So then they start nursing, which is great, helps develop the jaws. And then they start looking at like mushy baby foods versus like baby-led weaning, hard stuff to develop the jaws and the airway. So again, if you have a tongue tie, you're gonna have trouble with certain textures. Sometimes they do have trouble with mushy stuff like mashed potatoes or meats especially, but they really have trouble lateralizing a bolus, chewing. And so it's all integrated. It's hard to separate out the feeding and the speech and the sleep. And so fast forward a few more years. Okay, now they're starting to, they sleep restlessly. Although we have babies that are snoring and sleeping restlessly, had a few this morning, mouth breathing. Again, the tongue is in a lower position. It's encouraging a higher arch palate, making less room for the sinuses, less room for the nose. The nose is actually, it's like an iceberg. You can't see the majority of it. You can just see the tip of your nose, obviously. It goes way far back into your head. A lot of people don't realize that. But anyway, it keeps going on and just causing all these issues. Then your mouth breathing causes your tonsils to get big, typically from micro trauma. And then your adenoids get enlarged too, and they're not nasal breathing, which there's a book called Breath by James Nestor. It's a great one if you haven't read that yet. I actually haven't finished it yet. I've been working on it, but it's really good. But I can tell it's good. Like it's really well written. It's better than tongue tie. He's a professional journalist. I mean, he's written for the New York Times and like the Atlantic and stuff, but just the adjectives and like the words he uses, his diction is unbelievable. So anyway, all to say, you're having these airway issues starting from birth, really, and they happen until you're a grandpa or a grandma. Like it's a lifelong impact, and really it starts in that in utero period, in that or like early infancy, when they're having these things show up like poor sleep quality, and your brain is developing like 1% a day when they're little. By the time they're age 3, their brain is 80% size of an adult brain. By the time they're age 5, it's 90% the size of an adult brain. So we got to get to these kids early, fix whatever restriction they have. And then if they need expansion, take that route. If they need their tonsils out, hopefully not, but if they do, if they're too big already, the damage has been done, they're 4 or 5 or 6, get those out, adenoids or whatever the case is. So we got to really start looking at these kids on that regard, because all this comes back to their sleep quality, and sleep, that's when everything in the body resets. So these kids with sensory issues, often they have sleep issues. These kids with ADHD, I put in quotes, because often it's just sleep deprivation. They may get enough sleep, the quantity, but they're not getting the quality of sleep. So this is stuff we tell our patients every day. The sooner it's addressed, the more team members like you guys, the therapists, myofunctional therapists, CST, craniosacral therapy, chiropractors, pediatricians, get everyone on board. ENTs, obviously, get everyone on board to help these kids. The sooner it'll improve, and they'll see good results. So hopefully that was a brief overview that helped go where we're going here. But
yes,
absolutely.
So what are some symptoms of a sleep disturbance in children? What can we look for?
Yeah, so really it's a continuum. So there's sleep disorder breathing, there's like primary snoring, maybe noisy breathing, mouth breathing. Really mouth breathing is where it starts. So we have a lot of babies that are mouth breathing. So make sure moms close the mouth on the babies or push on the soft spot under their chin. You can kind of get that tongue on the roof. And it's a habit in a lot of kids, or poor oral tone, but for babies and stuff, it's a habit. So about a month or 2 of that, and they'll just do it naturally. That's where it starts, mouth breathing. Then it goes to noisy breathing. That could be congested, could be from reflux. It could be from reflux because they're swallowing air. On Long Island, Scott Siegel, he's an oral surgeon there. He wrote an article in 2016 called Aerophagia-Induced Reflux, or AIR. Basically, these babies have reflux, and reflux is not just back up in their throat, but in their nose too. They have like these milk boogers, and they can't breathe well, so they mouth breathe too. So you can get that corrected. Often tongue tie is part of that picture. To snoring, so babies snore all the way to grandparents. It's cute. It's not normal. Then it goes to sleep disorder breathing. So again, like basically the fire starts like it was in the pan, it got a little bit out, like it's getting in the kitchen now, like something's wrong. We need to put the fire out before it gets to obstructive sleep apnea, and which kids and babies can have obstructive sleep apnea. Often you think of just like the obese adult male, but really it is happening in kids all the time. In most cases, it goes undiagnosed. We skipped a couple there. So SDB, sleep disorder breathing, or breathing disordered sleep, however you want to say it. And then there's UARS, which is upper airway resistance syndrome. And then you go to OSA, obstructive sleep apnea. So that's really the continuum. OSA will take 10 years off your life. But even like just sleep disorder breathing, these kids will get misdiagnosed as behavior issues, or they're having, they're acting out in school. They can't pay attention. They're hyper. They get put on Ritalin, Focalin, Adderall, that kind of stuff, some kind of stimulant. And like you think, why would giving a hyper kid a stimulant make him calm down? It's because they're so tired. Why does giving you coffee in the morning make you able to be alert and pay attention? So they're just so tired. That's basically what it is, except it's speed. So it's not like good for you. Like coffee's okay. I drink coffee. But anyway, the sleep stuff is so critical. Like your immune system resets at night, your memories at night, like your brain is developing that deep sleep. So they may be asleep for 10 hours and not bothering mom and dad. And they're like, oh, he sleeps great. But without a sleep study, you don't really know. It gets a little bit complicated there because sleep studies aren't really reliable in a lot of kids. The PSG, like in lab, my girls would not sleep well in an in-lab sleep study. So there's a few now like home sleep tests you can do in kids. There's CPC, cardiopulmonary coupling. There's some pulse ox stuff. I just bought 5 owlets. I think they just arrived actually. I'm looking at doing like a study maybe with the owlet and seeing if we can do something there with babies to see if they're sleeping higher quality. So yeah, there's tons to talk about, and sleep is critical.
One of the things I think we notice most, especially with well visits, whether it be from infants through adults, that the frenum, A, is not assessed, but B, there's very little conversation or very little dialogue with a patient or their family regarding how they sleep and identifying the potential for this sleep disordered breathing. Do you see the same thing out by you and with your patients, and how do we change that, or how do we make that jump?
It's hard. So like we have like 4 or 5 minutes probably for a hygiene check. The hygienist is with them longer. So I mean, training the hygienist like in the dental practice, training the nurses, even like that can be talked to, like it doesn't have to be the pediatrician talking to, like even the nurses could talk to them. You guys as therapists can talk to them, obviously, because if they have speech issues, there's often, not always, but there's often a tongue restriction, and they likely have feeding issues or sleep issues as well. So typically it's those three plus a few other things. But like for us, for example, we're trying to screen kids for this. If we see they have, they're grinding their teeth a lot, the typical thing that dentists will say is, oh, teeth grinding is normal. It's common, but it's not normal, right? Like it's parafunctional. It's not ideal. And it's a sign that something's wrong. It's just a little like red flag. Snoring, that's a bigger red flag. Mouth breathing during the day, they're sitting there just gaping open like Napoleon Dynamite, or even just a little bit. It doesn't have to be that big gaping open, just to be a little bit. And if you see, and then you look over at mom or dad and their mouth breathing. So it's like, that's not normal. You should nasal breathe day and night. I try to even like nasal breathe when I'm working out even, which is difficult, but I try to. Anyway, but yeah, there's so many things that we could be assessing for. And the ADA, the American Dental Association, has actually started this like children's airway screening thing. I think it's called CAST. So they're trying to get that into dental practices and ideally identify this as dentists. Because again, the pediatricians, they're overworked. They have 15 minutes. They have to go over every body system. But there's this huge disconnect with the airway and tongue tie stuff, and then getting it into practices. Unless that person is passionate about it, they attend conferences on it, they had a kid with it maybe, or enough parents come back and say, my kid had this, it helped. My kid had this, it helped. My kid had this, it helped. That's what we do here. We tell all the parents, tell your pediatrician it helped.
Absolutely.
So eventually they'll say, oh my gosh, like 15 parents have told me this, like maybe Dr. Baxter's not crazy.
Anyway, yes, we hear that too.
We're getting there. We used to, like 5 years ago, it was like, don't see that guy. And now it's like, oh, are you all going to see Dr. Baxter? Oh, good. I hear he's the best. So like, hey, we're making some progress.
Yes.
So anyway, that's what one parent told us last week. I was like, really? That's encouraging.
It's very encouraging.
People, but
absolutely.
Right. What are some common causes of the airway being obstructed?
Yeah, so typically it's three main things. So the tongue, as we've talked about, if the tongue is held down, basically it's not in its home, it should be up in the palate. If it's down, it'll flop back in the airway, especially when they're laying on their back. And so then it'll choke them, essentially. They can't get enough oxygen. And it either narrows the airway or like it completely obstructs the airway. So then they'll try to move around. Like if your head's in the pillow, you'll think, oh, okay, I'm trying to like get a breath here. Your brain says, wake up and breathe. So you're moving around. So that's why they're restless sleepers. They can't get enough oxygen. Or they'll sleep with their bum up in the air, called tripoding, or they'll throw their head back like a CPR position, trying to open their airway. So the tongue is an often neglected reason. Most like pediatricians or ENTs, tonsils. It's like, that's like the shoot straight to tonsils. But then the large tonsils is a symptom of something else going on. Very often it is like chronic mouth breathing causing micro trauma, just a little bit over time of inflammation, irritation to the tonsils, and they get bigger because they're not meant to filter out. The nose filters the air, humidifies the air, cleans the air, and produces nitric oxides. That's why nasal breathing is so important. It is possible to shrink tonsils. It's difficult once they get to a certain size, but it is possible to shrink them with nasal breathing, myofunctional therapy, that kind of stuff. But so often people think tonsils and adenoids or TNA, getting those out, which can work, but they can regrow if the root cause was not taken care of. And then the third thing is like tongue space. So if there's not enough space for the tongue in the mouth, meaning your palate's high, again, we talked about because in utero is molding, and then bottle feeding, and then pacifier use or digit sucking because they're not getting the stimulation from the tongue being up on the palate. And now you have a really high arched palate, it collapses the jaws, and then your tongue doesn't have enough room to get into your oropharynx. So it's back, it's back in their throat basically, because it can't fit in your mouth. It's in the oropharynx instead of in your oral cavity where it's supposed to be. So those are the three main things: tongue space issues, tonsils and adenoids, and then the tongue being restricted or held down. I don't like tongue tie. I like the word tongue tie, but I don't, just because it's really a restriction. If you say tongue tie, people think it has to be to the tip. That's what I thought getting out of dental school. I didn't know any different, but really it can be restricted anywhere along that. It could be 50%, it could be 20%. We had a couple babies this morning. Mom had terrible 10 out of 10 pain, said, I'd rather be in labor. I dread feeding him, was her exact words.
Wow.
And it was just this tiny little bit there. It was like 10%, but it was enough for that individual baby. They couldn't get a deep latch because they couldn't move their tongue properly. So anyway.
We often hear when we make a referral to an ENT, especially in that 4, 5, 6, 7, 8 range, that the tonsils are developmentally enlarged and therefore we're not going to intervene. Is there a way for us to determine? I know many parents will literally wait till that birthday and with a wish and a prayer, they're going to shrink. Is there a way to determine that those enlarged tonsils are not necessarily developmental in nature? And that should be
probably like more a question for an ENT, like Dr. Zaghi. Maybe I'll get him on there. Dr. Park, Park's up there, and it's neck of the woods. He's in New York City, but I mean, if they're kissing tonsils, if they're touching, that's too big, and most ENTs would take those out. It used to be they took them out for infections and all that kind of stuff. Now, more tonsils and adenoids are coming out for airway issues because the child's breathing through a straw, right? And so if they're there's broad ski scales, 2+, 3+, or 50%, 75%, including the airway, basically. I mean, if they're larger, 2+, 3+, often those probably are not going to shrink. And basically they're saying to you, if they're developmentally appropriate, basically means it's common, they're fine. Which we hear, they'll live, but we're going for optimal, we're going for thriving here. And so if that's the case, you just have to find whoever's in your area that is more airway focused, and we'll look into that. Hey, they're not sleeping well. They're having all these airway issues, behavior issues and attention issues at school, whatever the case may be. And then they can use that picture, because just looking at a tongue or just looking at the anatomy, you don't know the whole story. So really, if they do a deep dive and look at all that child's symptoms, I think they'd be more likely to get them out if they were actually causing a problem. But I mean, there is risk involved, and there's morbidity, even mortality with taking tonsils out. I mean, some kids do die from getting tonsils out, so it's not unheard of. They can bleed out afterward. It's rare, fortunately, but it can happen. And it's sore. My daughter, we got hers out on her 3rd birthday, actually. And when I turned
Happy birthday. That was not the best present.
We celebrated the day before. We told her the day before was her birthday.
Okay, perfect. Yeah.
They're twins. Y'all read the book. They're twins. That's how I got in this whole mess in the first place. They had tongue tie issues. But Noelle, I mean, she had pretty good sized tonsils, was mouth breathing, dark circles under the eyes, all the airway issues. So we got her tonsils and adenoids. She got ear tubes out too, just so she couldn't hear anything. And anyway, so she did better after that. But it was 10 days of miserableness. I didn't even know they give oxycodone to kids, but she oxycodone didn't even touch it. It was oxycodone plus Motrin plus Tylenol, and then she was kind of okay. It was pretty rough for
now,
10 days.
Can that happen in a vacuum then? So if the ENT takes out the tonsils and or adenoids, and the frenum is not addressed, or that tethered oral tissue is not addressed, is there still likelihood that you'd see improvement, or does it need to?
Often.
Yeah. Okay. So you don't need to have both of them done in order for that to be successful.
Well, it's complicated. So very often there is some improvement, but not all the way, as I was getting it to. So very often it helps, but then maybe 3 months later, 6 months later, but he's still snoring, or he's still mouth breathing. Then take care of the root problem. So myofunctional therapy, 3 main goals of myofunctional therapy is getting the tongue up on the palate. So proper oral rest posture, the lips together, so lip seal, and then nasal breathing 100% of the time, the day and night. And so there's different ways to achieve that. I'm sure y'all talk about that all the time there, but so that's critical. And that's often the missing link for those people. If you just cut the tongue and don't do any myo, it helps. Honestly, it helps, but long-term, they'll go back. And so anyway, same thing with the tonsils. You get the tonsils out, it helps, but long-term, if those habits are not addressed, then they're gonna have issues. Right. So. And the tongue tie too. We have tons of kids that had tonsils, adenoids, who still have terrible sleep. We do their tongue tie, combine with myo with our local providers, and then they do a lot better.
Do you find that the tongue tie on its own can be what's causing a sleep disturbance in children? No enlargement of tonsils or adenoids?
Yeah, that's often the first thing, honestly, kind of the chicken and the egg. Probably that happened first. They had some kind of tongue restriction. It doesn't have to be to the tip. Again, it could be halfway back, but for function are more important than appearance. then that could be what's causing the issue. So combining that with therapy and other team members, I think is your best bet to get them better, and hopefully not even get the tonsils out, because putting them to sleep, they're not getting 4 bills from Children's Hospital. So it very often is easier on parents. It's about as traumatic as a flu shot. I mean, literally they cry for like a couple minutes and then go play on the playground. It's not that bad. And yeah, it's sore for a couple days. I'd probably say like 4-ish pain versus the tonsils is like 10 days, maybe like 6 or 7 pain. So
in terms of reattachment with scar tissue, do you see an increase in symptoms associated with sleep disordered breathing when a patient, say, does not work to stretch their tongue or mobilize their tongue post frenectomy?
Yeah, so often we'll see is like it improved for a week or two, and then it's like getting a little bit worse, a little bit worse, a little bit worse, a little bit worse, and like so it's growing back together. And it's like a light switch. Like if you push on it, it stretches back out, and like they sleep better, or they talk better, or whatever, or they're nursing better, and then it grows back and it gets worse. So like it's really highly dependent and it's highly variable. So we always try to give the kids the most mobility because we don't know at what point is too tight for Johnny. So we always encourage them to come back at least at 1 week for just to check it, make sure it's healing nicely. Most parents do not push hard enough. They don't want to hurt their child. I don't want to hurt them either, but I also don't want them to go through another procedure and another 3 or 4 weeks of stretches. So basically, yeah, it can grow back together and it can impact speech, feeding, sleep, nursing, breathing, all those things when it does reattach. And so often like up to a month, sometimes even 2, you can push on and it'll stretch back out because it's healed on top, but not below. It takes about 6 to 12 months to fully heal under the tongue, which is interesting. So often we don't even have to go back and re-laser it. But if it's been a little while, and the older patients, like adults, then you're probably gonna have to go back with the laser quicker. Although we try to wait if we can at least 6 months just for the healing, so it's not kind of gunky in there.
How soon should a parent or we as the clinicians notice a change and or make the referral back for a revision procedure or for another consultation?
Yeah, that's a good question. So, I mean, ideally they follow up at least at 1 week, like 7 to 10 days with a release provider to check on the wound healing areas. You guys obviously can check it too. You can probably put on some gloves and check in there and, help the parents with stretches or something. I'm not sure, depends on what state you're in, obviously.
Yeah.
How detailed you can get. But yeah, it's helpful for everyone on the team to check. It's not an infection. It's a whitish, yellowish scab, sometimes even greenish in babies, but not infection. We never seen it get infected. Dr. Kotlow up there in Albany, he's done like, I think 50,000 or 40,000 procedures, something like that. Never seen one get infected. We've never seen one get infected here. So the mouth is nice. It heals really nicely, but it can grow back very easily. Just like, again, the earring example, if you got your ear pierced, we left it out, it would grow back. But if you put the earring in a few times a day, like it'd be sore, but like you could keep it patent, you could keep it open. So essentially that's what we're trying to do. The body heals up like perfectly 99% of the time. We're glad it closes back up a few situations. We want it to heal open. So we're trying to trick it to heal open. And so that's what we're trying to, it wants to do that. That's what it's pre-programmed to do. The myofibroblasts are supposed to contract and the wound healing and the collagen is supposed to, but we're trying to just disrupt that and keep it as best we can. So in kids, we say like 2 to 3 times a day for stretches. Babies, we say 4-ish times a day for stretches for about 3 weeks typically. Gentle but firm pressure. Again, not trying to hurt the child. And we use a couple of different tools. So we'll actually give parents a molt mouth prop to take home with them. We can get some for about $4 or $5. And so, especially the 2 or 3 year olds, because that's like no man's land, right? We've had people drive to us. One family drove to us from Wisconsin to treat their 2-year-old because they only want to put them to sleep where they were. So it was 24 hours. I just got off phone with a lady from the UK. She wants to come see us because no one there really treat her 4-year-old, and they want to put her to sleep, or no one really do it because it's not to the tip. It's like halfway maybe, but she has all the symptoms, and so they may come see us. But anyway, all that to say, the 6-month to 2-year-olds or 3-year-olds get neglected because parents think they can't do the stretches, but there are ways to do stretches creatively or with the right tools. And again, that brain development, speech development, feeding development, all those things at early, like preschool years, we got to get that as soon as possible. So in my mind, if it's my kid, hey, it's worth a shot. Even if we can give him like 80% better mobility, not 100%, but we're getting as good as we can currently, knowing that we may have to go back in there when he's 5 or 6. Most of the time we don't though, and they're able to get it good enough for them, and they're very, very glad we do it at that age. So And we're not putting them to sleep. It's literally 10 seconds.
Right.
Yes. We've watched a few of them. They're quick, yes, but
no shots. Like it's just
No.
some jelly and then the CO2 laser.
Yeah. Do you notice a difference with regards to individuals that are symptomatic for sleep disorders when it comes to using the CO2 laser versus traditional scalpel cut procedure?
I've never actually done it with Scalpel. I've used electrosurge and I've used diode. But yeah, I guess from the OR operating room, I'll just use the electrosurge because I don't have laser privileges. It's pretty difficult to get at the hospital.
Okay.
And we used a diode laser about 18 months when we first started doing it. Then we switched to CO2 in 2016. But all that to say, we did notice a difference in pain with like, especially nursing babies, because they won't lie to you. If they're sore, they're not going to eat.
Right.
Even with Tylenol, they wouldn't eat. So with the CO2 laser, it's less painful. It's much quicker of a procedure versus 1 minute per area. So 1 minute for the lip, 1 minute for the tongue. It's about 10, 15 seconds for the lip, and then about 5 to 10 seconds for the tongue. And on a moving toddler, you can bump the power a little bit more and do it a little bit quicker, even 3 or 5 seconds. Even for a thick one, you can do it pretty quickly. So that's what's nice about the CO2 laser. You can adjust it depending on what you need. But as far as the differences go, as long as the procedure is done properly, you can do it with scissors, you can do it with scalpel, you can do it with electrosurgery or laser, but making sure it's a full release. Often that's that diamond shape. We're not making a diamond, just a horizontal cut through a triangular prism will give you a diamond shape. See the diamond there?
Yep.
Anyway, but yeah, you cut horizontally through a triangular prism, it makes a diamond.
Yes.
And so we're not going deep. We're not taking muscle. Sometimes in adults, that's a whole different discussion. They get a little bit of the genioglossus muscle, but we're not taking muscle in kids. Just the mucosa, which is the top layer of the floor of the mouth, and then the fascia, which is the connective tissue, which is connected all the way from your tongue all the way down to your toes. It's one piece of fascia. So we'll have kids report they can move their neck easier. They can breathe easier. They just feel like more open, like a weight's off their chest. So yeah.
Yes, we've definitely heard that.
It's not just our patients here. Yeah, it's all y'all patients up
It's
there.
everywhere. Yes, it's everywhere. It's
I'm
everywhere.
not just making this up.
Yes, no, it's so true.
But it sounds magical or fantastical. It's like, really? Like, does that really happen? It's like, after like 50 people come tell you the same thing, it's like, well, I guess this is a thing. Like, my kid's less constipated. Like, well, I guess it's a thing.
Yes.
And the explanation behind it. Like, they have less reflux or whatever the case is. Less hiccups even. Like in little babies will do it. They hiccup much less.
Yes,
So.
less air in the belly.
Yep. Anyway.
What are some speech deficits that you've seen with patients that have a short lingual frenum or have that low resting posture of the tongue?
Yeah, so traditionally it's like R's, L's, S's, SH sounds, TH sounds, like K's, ing. So velars, palatal, alveolar. I'm not sure who listens to this, but interdental. Like there's so many speech sound issue articulation errors, but that's typically where it stops as far as like the literature. We came out with the article in 2020. Looked at the whole thing. It's like mumbling, like speech delay. So ours was the first article to even connect, like, hey, some of these kids with speech delay, like actually have a tongue restriction. And unless it's released, you really don't know. It's almost like the best diagnostic test to tell, like, well, is it just like all in the head, or is there actually something going on with the tongue restriction? It kind of reminds me of how, like, when you smile, even if you're not feeling good, if you smile a lot, it makes you feel happier. Or if you frown a lot, like it's a bi-directional relationship. Or if you're obviously happy, then you'll smile. Like it goes both ways. So if you can move your tongue well and explore, they're going to start trying new sounds and new words. I mean, we have some crazy results with new words. Let's get off topic, but like there's so many speech things. Stuttering, we have some crazy videos of stuttering with adults that we've released, not to the tip. They were probably halfway.
Wow.
And they stopped stuttering immediately. Like, we had them say the Pledge of Allegiance before and after, or like the Rainbow Passage before and after. And like, we have a video of a grown man crying. He said, I've been waiting. I thought it was because it was hurting because we just did the procedure. And Lauren, our speech therapist who did the speech chapters for the book, she was in there too. She saw it. I have it on video. It says, I've been waiting my whole life just to say a sentence without stuttering. I was like, oh my gosh.
Wow.
This one mom had a lot of, like, I think it's called secondary features. She's like kind of like a tick almost. Like when she was stuttering, it's really bad. The worst stutter I've ever seen. I did it for free for her. I was like, let's just try it. It will probably help. She said a sentence with the fluency was unbelievable. She could talk totally fine, didn't stutter once. And she couldn't even get through 2-3 words without stuttering. It took her like 2 minutes to say the Pledge of Allegiance. I mean,
Wow.
Anyway,
Wow.
crazy.
Amazing.
So
Yeah.
adults, kids can have obviously issues with stuttering too.
Mhm.
Yeah, we have a whole list on our website of like all the symptoms on that intake form.
Yeah.
I was going to say, and those videos I think would be tremendously helpful if they're
Mhm.
accessible to us, just for us for showing our
hard.
patients.
Yeah, it's hard. So like I told her I wouldn't share it on Facebook. And so it's
Oh,
like if I
okay.
link
Okay.
this on
Yes.
Facebook,
Don't
I'll
share.
show them. If they
Yeah.
ever invite me to speak at ASHA, which I'm like not holding my breath on, I applied a couple of years ago with Melanie Potok. If you want to know Melanie, the feeding lady in Colorado,
Yep.
the Adventures in Veggieland, not healthy eater. I applied, it was probably 3 years ago to ASHA, I guess naively. I was like, we didn't get accepted, but
I'm shocked.
I know, I don't know why, but hey, I spoke for BASHA, the Bay Area Speech and Hearing Association, Mobile. I'm like, how have we never heard about this? I was like,
Yes.
invite me to Alabama, Shaw. I'll be happy to talk. It's like, just down the street from us, their convention in Alabama for all the speech therapists. So that's my next stop. And then hopefully after that, we'll see if we get to the national ASHA conference. So
Excellent.
one of
Excellent.
these days, but I'll show it there.
We need it. It's so true.
Like you can't argue. It's like literally here's the before and after. Like immediately afterward. The video is probably 5 years old now, but it was really quick.
Wow.
Do you feel that you see the improvements or the symptoms more specifically in an anterior or posterior tongue tie, a buccal tie, a labial tie? Do you notice more patients have symptomology when they have all of those other things, certain types of ties?
Yeah, that's a good question. So with that, so we basically referencing that study from 2020. So it's basically we had 37 patients. We actually had more than that, but it's hard to get people to follow up. And like we did this prospectively, meaning before we knew if it was going to help or not, we said, whatever happens, you're in the study. We're going to report the data. So it's a cohort study. So we treated them, checked them at 1 week, checked them at 1 month to see how they improved. That's like, a lot of them are doing therapy, but this is like basically just looking at the results of the procedure.
Okay.
And so with more therapy, you think the results are even better. But what we found was that maybe 75% to the tip, 100% to the tip, 90, anywhere in there. And posterior tie, which is like maybe 50, 40, 30, 20%, just barely there. There was no difference as far as whether they improved or not.
Okay.
There's no difference. So the only thing we really see like a trend with is for moms that are nursing, the really painful latch very often is a posterior, not obvious tie, which is highly unfortunate because those are the ones the moms go in and say, please help me to their primary care providers. And they say, there's nothing there, mom. It's all in your head, or there's no tie, give them a bottle. What's the big deal? Unfortunately, we hear all kinds of stories like that, not to rag on pediatricians or anything, but that's the stories we hear. And so what happens is we do the procedure and then the pain goes away or whatever the case is. And there was just barely there, like the ones this morning, but like for that individual child, that was too tight. Now, if a child had that and had no symptoms, would I do that? Of course not. Like what? If it ain't broke, don't fix it. Like,
right.
But they would never come see me unless there's a problem really. Like I'm not going to go to the endodontist, say, hey, can I have a root canal?
Yeah.
Sure, which tooth's bothering you? None. I just, for fun, I thought I'd get a root canal. Yeah, number 19.
Yes.
No, like they don't want to put their baby through this. People are not trying to put their child through this, but if it could help, then hey, it's worth a try. It's 10 seconds, minimal risk, potentially great reward. It's sore for a couple of days. Biggest risk is probably financial. You paid the money, didn't help as much as you wanted to, but even that's rare. So most parents like, yeah, let's give it a try.
And I think
autistic kids start talking afterward. I mean, it's crazy.
Wow. I feel like that educational piece is so important. We have so many families or mothers that come in that exclusively breastfed their child and are still presenting with all the symptoms as if they were bottle fed or, and, again, for them, they followed all the literature, they followed all the quote unquote rules, not realizing that what and how they're mobilizing their tongue to facilitate their nutrition and to facilitate that suck may be more of the issue than the actual, all right, I breastfed my child.
And that's the thing, like, so like a lot of babies breastfeed, but like, are they doing optimally? Are they efficiently feeding? Or sometimes like if it's first baby, they're on the boob all day, constantly nursing, and mom thinks that's normal. Like they never get full. They're just kind of like lazily eating all day. And there's no such thing as like a lazy eater. It's a sign that something's wrong. The babies aren't choosing to be lazy. We had a speech therapist in here yesterday, a mom, this was her fifth kid, and baby had a pretty impressive tongue tie. The pediatrician even said it was a tongue tie. So that's how you know it was tight.
That's a good, yeah, exactly.
It was pretty obvious. But she only had a few check marks, like maybe 5 check marks on the form. Of like maybe some like gassy and like spitting up and like, yeah, it takes a little while to nurse, but like not a whole lot. And then I looked in there, I was like, oh, wow, like that's impressive, like big, thick lip tie. I was like, I mean, even just for like dental reasons in the future, but like you are having current issues too. And then like the tongue was like 90% of the way to the tip. It was pretty impressive. I was like, I don't have a crystal ball, but if it was my baby, I would do it. It's much easier to do stretches now, develop normal speech, feeding, sleep, if nothing else for peace of mind. And so she's like, okay, let's do it. And she did. But like, it wasn't, she's like, I can nurse him just fine. It's not painful. He's not losing weight. You know, we're okay. I said, I don't want speech therapy to be his sport. No offense.
No, none taken.
I want him to, I don't want him in therapy twice a week. Like I want to be able to play soccer or whatever. Cause like having kids, oh my gosh, like they're doing ballet. Actually, they're going right now to ballet. Like once a week, like that's pretty much all we can handle as far as, you know, like extracurricular activities with 3 kids, you know, like pick one thing. Like you can't do like ballet and soccer and gymnastics. Like you can't do all of them.
Yep.
So anyway, you can't do like therapy plus, you know, feeding therapy plus, you know,
it's true. It's a commitment.
And baseball, you know.
Right.
So it's just quality of life issues for these families. And another thing on that note is like the pediatricians will be like, oh yeah, he's fine, right? Like he'll live is basically what they're saying. Like we're not going for like survival here. We're going for thriving. Like we're going for optimal. Right. We'd like them to, meet all their milestones or exceed their milestones. Like no one just wants like a C student. We want them to get an A+, or at least have the ability to get an A+. And not have to compensate for their whole life. You know, if their arm is tied to their, to their side, I mean, I can kind of throw a ball, but like, no, untie your arm, you can really throw a ball. So that's kind of the difference we're seeing. So they're limping by, they're getting along with nursing. So they may not come see us until they see you guys, or speech issues or eating issues, myofunctional disorders. So all that to say, we have lots of people that's the case. We also have a lot of patients that struggled where they were on the struggle bus as infants, and then they now have all the speech issues, eating issues, sleep issues, constipation, reflux, all that stuff, airway issues. And then, we've released them at age 10 or at 30, or we did a speech therapist who was 60 about a month or 2 ago.
Wow.
So,
In terms of assessment, seeing that this starts in utero, should a child or an infant be assessed at certain times, regardless of symptoms, as I feel like so many times the parents don't realize that there are actually symptoms?
If I had it my way.
Yes, I want to know what it would do if you had it your way.
Ideal world. It's like in Brazil, there is a frenum inspection law. Marquesan and Martinelli got that put in place there. The Testado de Linguaje, I think that's like Portuguese for like the freedom inspection law. And if someone speaks Portuguese, I just butchered that really bad.
We don't, so it's good. You sounded great.
I speak Spanish actually, but anyway, but the Portuguese, it's like testa de lenguaje or something. But basically, it means that they're going to inspect the baby's freedom. But then it's not like ideally, like not everyone's checking it right in the NICUs or in the nurseries and stuff. So ideally, they would be assessed at birth by multiple providers, probably. So whoever's counting how many fingers and toes they have. So the nurse, we have to take away the gag orders, so they can't. A lot of times, they can't tell the parents they have a tongue tie. They could be fired. And saying there is or is not a tongue tie, as Dr. Kotler likes to say, is a diagnosis. Saying there's no cavities is a diagnosis. So when the nurse or lactation consultant or other people that aren't supposed to technically diagnose say there's no tongue tie, that's giving a diagnosis.
Got it.
So they should check it and say, hey, this looks suspicious. Maybe we should get this looked at. But that's only going to pick up the obvious ones, like depending on what classification system you use. I'll just say percentages because it's easier. You don't have to know if it's Carillus or Kotler or whatever. But basically, if it's like 75% of the way to the tip, 100% of the way to the tip, those can be picked up, and those should probably be released pretty quickly after birth because we know that's going to cause an issue. If it's 50%, 25%, it may or may not cause an issue. So then inform the parent, say, hey, mom, the tongue is a little bit tight. If he has 0 problems, here's the list of all the things that could happen, not just like pain or losing weight. I made, as a joke, like a list of the pediatrician check marks that like their form, if it was our form, and they only had 1 check mark on it, said, are they gaining weight?
Yes, we get those a lot. You mean you never have that issue? Of course they did. I'm
it's on our Facebook page. It's like, It's like the pediatrician form. It's like, just, are they gaining weight? Yes. Okay, they're fine.
Yes,
Like they'll live. Like,
Mhm.
again. Anyway, but checked then, and then checked, well child checks at dentist visits. I mean, if I see a kid just for their teeth and it looks a little bit tight to me, I'll say, hey mom, any speech or eating or sleep issues? And you can tell pretty quick if they don't talk about it. No, he's fine. It's like, all right, well, no cavities. Here's a fluoride. Bye-bye. See you in 6 months. But I'm like, well, what do you mean? Like, well, sleep issues would be like restless sleeping, snoring, grinding teeth. Eating would be like picky eating, real slow eating, like texture issues, trouble with meat or mashed potatoes. Like, how did you know? It's not always meat and mashed potatoes, but probably 60, 70% of the time it's meat and mashed potatoes they can't do.
Yes.
And then the speech stuff we'll go over, like as we talked about, speech delay or like articulation or even baby talk, like hypernasal. They're just kind of, like talking like a baby, which is cute when they're 3 or 4, not cute when they're 10.
Exactly. Exactly. Use your
Anyway.
big boy voice. We hear that a lot.
Yeah.
Use your big boy
And
voice.
the parents feel so bad. They come back a week later. They're like, oh my gosh, I was getting on to him. And it was just his tongue the whole time. Like he was a messy eater and eating slowly and picking at his food and talking like a baby. And they feel bad. I said, well, don't feel bad. At least we got sorted out what it was. But
Right. You addressed it. Exactly.
Right.
Exactly.
I think we get that a lot too, when we tell them the way that they're chewing, the way that they're swallowing isn't appropriate. And this might be why they're staying away from certain foods. And then the parent, feels terrible, but it's not their fault.
Right.
Picky eating is 100% just behavioral. Like that's just Johnny. He's a picky eater, which
Yes.
there is an aspect that's learned behavior, of course. I mean, maybe 50% is, learned behavior, but the other 50% could be like, there's a reason why.
Yes.
That's a physical restriction or something like that.
Mhm.
So.
Absolutely. How do you approach the parents that are maybe a little hesitant to do the procedure? They're nervous, they're not sure that they want to undergo that. What is your approach on that?
Right before I just talked to the lady from the UK, I had another parent close by that they were supposed to come see us tomorrow, and pediatrician said, oh, don't go there. You don't need to have it done. And so I called her just to answer some questions. So just like being real with them and leveling with them. I said, hey, mom, have you seen like our assessment form, our new patient form? She said, no. Go ahead and fill that out, see how many check marks there are. Because again, like how many issues are there? And really it depends on kind of the severity of those. So sometimes they'll have several things, but like, it spits up occasionally or not a big deal. Gassy, but not that bad. But sometimes it's terrible gas. Like they toot like a grown man. They burp like a grown man. They're colicky. Colic is horrible. No baby should have to go through that, or parents should have to go through that either. So seeing how bad the symptoms are affecting quality of life, how many there are. And then I said, hey, send us some pictures. Let us know what it looks like. So, I mean, if it's like, really super tight, like yesterday and just a couple of check marks, hey, it's probably worth doing. And then just saying, tell them honestly, if it was your baby, what would you do? And then, giving them options and say, like, we never guarantee it. If I guarantee it won't work. We had one mom come up and she said, if there's a 2% chance of this helping, I want to try it. Kid was nonverbal, autistic, 9 years old. I said, it's probably 50-50. Like we'll get something, right? He maybe will sleep better. Came back a week later. He was sleeping so soundly, mom thought he was dead because he wasn't snoring anymore. He was so still, like, is he still breathing? Like he was quiet and still and like not restless all over the place the first time. Started talking. He had several new words. He said, Mom, for the first time, he came in and said, hello. Like, it was crazy. Eating better, like tried salad for the first time. So less picky with textures because he could lateralize his tongue and move food around. And she was like 2% chance. So the numbers I kind of hang my hat on there, again, from that study we did, 89% of the time they spoke better. So not 100. And this is within a month. So with therapy, like that would be higher, but just the procedure, 89% of the time they had better speech, 83% of the time better solid feeding. Before our article came out in 2018, speech and feeding improvements after posterior tongue tie release. You can Google that and it'll pull it up. But yeah, there was not a single article connecting feeding and tongue ties, not a single one. Since then, there's been Brooks in 2019. She's a speech therapist, feeding therapist in Atlanta. And then our article came out, which was looking at the 37 kids. And that was the most comprehensive I know of that I looked at picky eating, slow eating, like choking, spitting out foods, all that kind of stuff. So 83% of the time we see improvements with solid feeding, and then sleep, it's 83% of the time we saw improvements with sleep, like deeper sleep, less restless sleep, less snoring, mouth breathing, less gasping, that kind of stuff. So it's not every time. Often they'll get maybe 2 out of the 3. Some might get speech and sleep, but not eating, or eating and speech, but not sleep. It's kind of random. We don't exactly know what we're going to get until they come back a week or 2 later. So.
We often get a lot of pushback, especially if a child is tongue-tied, but they can get their tongue to the vermilion border of their lip. Therefore, they don't need a frenectomy. And
Yeah, right.
so I don't know how many of us walk around like that. Yes, exactly.
That's barely at all. Like that's not even to lick an ice cream cone. Like,
Yep.
Kiss your wife when you're older. Like
Yes.
things. Yeah. So all that to say, it's the worst test. Like I was like, sticking your tongue out is the worst test.
Yes.
Elevation is the best quick and dirty test. If like I'm on the street and someone's like, do I have a tongue tie? It's like, let me see, lift your tongue up.
Yes. that definitely could be misconstrued wrong, right? On the street, but absolutely.
Yeah, like lift your tongue up. It should lift most of the way, like to the right behind your teeth. You should be able to open a comfortable amount, lift your tongue up. It should go most of the way. So you're just using the tongue range of motion ratio from Audrey Yoon and Sarush Sagi. It should lift up, like 80% of the way, 100% of the way, ideally.
So if you're a parent,
but even that's misleading because some people are compensating.
Right. If you're a parent, what are some things they can do, especially in an infant or a toddler, to assess if their child is tongue-tied?
Yes, checking under there, you can run your finger back and forth underneath. If it feels tight, like a guitar string or like a speed bump, then likely there's an issue. That's from babies up until older kids. Okay. And then really it's symptoms and function are more important than appearance. So if they are having speech issues, eating issues, sleep issues, especially those three together, the more issues they have, the more likely it is a problem with the tongue. Snoring is not normal. A lot of things that are common are not normal. So keeping that in mind, and then having it assessed by someone who does this routinely. We do, 30 a week or more, right. Just depending on the week. Probably do about 50 this week, actually. Wow. But it just depends on, who's in your area. And unfortunately, that comes down to probably checking Facebook moms groups. So every state has a Alabama tongue and lip tie support group, or Colorado tongue and lip tie support group. New York, I think there's a Northeast tongue and lip tie support group. And so I'm not in those groups. They don't allow providers in them typically. I think the Texas one does. But anyway, it's just moms saying hey, I want to see this person. I don't want to be in the Alabama one. They're just talking about me all day, probably. I don't want to do that.
Exactly. Good, bad, and different, right?
It just stressed me out. And oh, I heard about you on Facebook. I'm like, hopefully good things. Yeah. Oh no, all good things, glowing things. Okay, good. I'm glad. Thank you. So that's how I check in on it. They'll tell me if there's something. But all that to say, checking those Facebook groups often is probably the best way to find provider recommendations for your specific area, and then have that person assessed, because your average pediatric dentist, general dentist, speech therapist, lactation consultant, pediatrician, ENT, unless they've taken a certain interest in it, attend recent continuing education courses on tongue tie, they're not going to be able to assess for it properly, sticking the tongue out past the wet dry line, which is what they told us in dental school. And that's completely wrong, not even close.
Right.
A lot of kids can stick the tongue halfway down their chin and they still have their tongue tie.
Yeah. Yes.
So some can pick their nose with their tongue and still have the tongue tie or tongue restriction. So that's why, again, the restriction, tongue restriction, what's that? Maybe they have it. Versus, oh, no, he's not tongue tied. He's not to the tip. That's what I thought when they told us our girls had a tongue tie. And I said, no, they don't. I would know, right? I'm a dentist. I wasn't quite that arrogant, but I was like, really? You think that's a tongue tie? I don't see anything there. And then, but I was open-minded enough to say, okay, let's look at the evidence and see what's going on here. So anyway.
That's great.
Yes. I think you've said something before that has really resonated with Janine and I that we've heard you say, and it's breathe through your mouth as frequently as you eat through your nose. Never.
Yes. I wish I came up with that, but
yeah.
I can't exactly. I don't know. It's probably in the book or somewhere, but I heard it somewhere. But yeah, basically it's true. You shouldn't. Yeah. Do you eat through your nose? No. Okay. The mouth is for eating and drinking, all that stuff. The nose is for breathing. Do not breathe through your mouth. And that book, Breath, goes into way more detail than tongue tie does or other things. But and it's you get, I think, 18% more oxygen just breathing through your nose. Your ethmoid air cells in your nose make nitric oxide, which helps the rest of your body get it. There's so many benefits. You're breathing. They've done studies. Harvard's monkeys, they clogged up their noses and they were mouth breathing, changed the shape of their jaws. They were sick and felt terrible, brain fog, all that kind of stuff. And people, the author in the shoved stuff. Have y'all read the book yet?
No.
He shoved, you should get it. It's good. But anyway, he like shoved stuff up his nose, like silicone, like earplugs, but up his nose for like 10 days, I think. And then to see the difference. And then they took him out, and then they measured like all these tests on themselves and him and this other guy. And it's interesting, just the way they felt way differently. And you know how it, like when you're sick, but a lot of it, if you're clogged in your nose, you're not breathing through your nose, it makes you feel even worse.
Yes.
So yeah, nasal breathing is critical.
Mm-hmm. How, I know you had mentioned that, again, you can see the impact of that inability to elevate the tongue with a tethered tissue or a tongue tie in utero. How soon after they're born do you start to see that the palate has been affected? And then how soon after, say, the release of that tissue, can you see a change in the palate?
That's a good question. So it's pretty variable. So sometimes we'll see a baby with toothy tip tongue tie or a posterior tie, any degree of restriction, and they have like a broad, beautiful palate. So it's like, whoa. I mean, part of it's genetics, but part of it also is the like in utero molding. And so very often they come out and like you feel it. And lactation consultants will call it a bubble palate or high arch palate or V-shaped palate, something like that. You can even have a cleft palate. So often cleft kids, they will have a tongue tie as well that often goes undiagnosed because everything gets blamed on the cleft. They're doing there at the palate. No one ever checks under the tongue. They put like a retractor in there, putting the under the tongue. For like a 6-hour surgery. No one checked the tongue. But anyway, that's a little tangent. But so as far as when it's released, and then with breastfeeding, nasal breathing, so closing the baby's mouth, you can see that palate start to mold up. I don't know how long though. It's a slow process. It's not quick. As they get older, I mean, you could consider something like expansion. So there's various ways to do that, like rapid expansion with like a normal, traditional orthodontic appliance, where there's slower stuff like ALF. There's the glelite growth appliance. I took that course. We don't do any. I'm busy enough with tongue tie stuff, but there's lots of different ways. BioBlock, orthotropics, like there's all these different ways, Crozats, to expand the papilla or expand the dentition, and hopefully expecture or get some additional skeletal growth and not just dental growth as well. There's DNA appliances. There's like a million different ones. Essentially, you're trying to expand the palate to give more room for the tongue, but also so the tongue can get up out of the airway, but also expand your nasal volume as well. If you can expand that, it's like to the 4th power, I think, or to the 8th power. I can't remember exactly as far as Poisson's, that's like a French man law, but basically the resistance when it's expanded 2 times, actually it's 8 times less resistance with twice the volume.
Wow.
So if you can get a small change into the nose, and
it's an exponential difference. Absolutely.
Yeah, it's exponential. I can't remember exactly. Don't quote me on it. It's like to the 4th power or something like that. So
that's way beyond me.
16 times less resistance, I think, is what it is. I think it's to the 4th power. So a small change in structure can make a huge difference in the function. Questions I can answer for you?
So as far as we didn't go too much into labial frenum. What are you seeing as an impact on lip strength or lip closure that obviously will help support that nasal breathing?
Yeah, so what's interesting is we release lip ties for various reasons. So in babies, often it's seal issues. So like the milk leaking out of the mouth, they can't flip their lip up, sucking blisters, reflux, gassy, colicky, air swallowing stuff. That's more seal issues, probably more lip. It could be partially tongue, but I think it's kind of lip is definitely at play there. As they get bigger, we're doing it because they can't brush their kids' teeth. Their 2-year-old or 3-year-old's fighting so bad. They're shaking their head. They can't keep it clean. There's a bunch of plaque accumulating up there, or even food trapping up there. BP and M and W sounds, so bilabial speech sounds, can also be impacted by lip ties. Getting food off a spoon, so they'll flip the spoon over and often get it out because they can't use their lip to get the food off a spoon. And then nasal breathing is the other reason. So nasal breathing is interesting though, because it's that fascia, again, like under the tongue, when you release the tongue, they can breathe easier, like move easier, like not pop their knuckles as much, like crazy stuff like that. We hear when you release this fascia up here under the lip, it like opens all this up and they can breathe easier through their nose just from that fascia being gone. So it feels like there's a maneuver you can kind of push on the sides of your nose and open it up and like those breathe right strips, kind of essentially. Basically doing that, it's like a permanent breathe right strip is what people describe it as when that lip tie is gone. Like that 6-year-old speech therapist I told you about, we did hers. Hers was tiny, just this little bit here. Like if you want to, I'll try it for free, just see what happens. We did it. And then she's like, I can breathe through my nose. This is crazy. Hers was minimal, like barely there. We just did a 41-year-old. He came back yesterday, said he can breathe a lot better through his nose, this guy. He wasn't like the frou-frou guy either. He was like, like a mechanic kind of guy,
Yeah, the big burly guy who.
Yeah, he's not like, this, I don't think he's even doing myo. Don't tell anyone. Like, some of these people, like, they won't do it. Like, so there's ideal and then there's real world.
Yes.
We have one myofunctional therapist in the state. She has a waiting list.
No way.
Yeah, we tried to, if anyone wants to move down here. And and speech therapist, you can't work across state lines. So like you can use a dental hygienist via Zoom like we're doing now, but I mean, there's only so much you can do over Zoom. So we encourage everyone to do myo. I prefer everyone, we strongly encourage and recommend it. Occasionally be like a dad and it's like really bad. I'm like, well, here's some exercises, do the best you can. And they still have some good results where it was worth it for them. It's not ideal, but you do the best you can.
Better than nothing.
Absolutely. We tried to leave better than we found them. I mean, but
well, honestly, this was so. I could keep you forever.
If I was in New York. If I was in New York, I'd be like, yeah, no myo, no release. But like, Alabama's not that backward, but like, I mean, it's still, it's not like it is on the coast, kind of. So.
Yes, I think so many people portray themselves as myofunctional therapists, but don't necessarily have the background and understanding, which makes it very challenging for us. And for families, because they think they're seeking the proper professional and they're not.
Of course, and like it doesn't necessarily make you a myofunctional therapist right away, or even a weekend course, something like that. And there are obviously good courses out there. And we tried with COVID. We did like we tried to train several of our hygienists to do it because I was like, you're going to have 3 myofunctional therapists here, like all this stuff. And then COVID hit like right then. So this is in March or January is when we started 2020, and then that whole thing. And so they forgot most of the stuff. And so now I have really well-trained hygienists to pick up on it, but they're not like doing the myo. And we're so busy cleaning kids' teeth, they don't have time. So it is difficult to get started. It would be easier if you're a speech therapist and already seeing clients like that model, but for the dental hygienist to start doing it, it's harder.
Absolutely. Well, this was so wonderful. Thank you so much for taking the time to talk to us and answer our questions. We will definitely have this put out there associated with everything that we do in our practice in our facility. But it's really just the education, I think, more and more from a professional and from a parent and patient standpoint that just continues to improve the research, the case studies, and the overall background knowledge. I know since I've been doing this the last 20 years, it's grown exponentially in terms of
crazy.
The studies, and it's really tremendously beneficial, especially as we're training therapists to become myofunctional therapists for them to understand this. So thank you so much for becoming part of our foundation of learning, and hopefully we'll get to cross paths sooner than later.
Yeah, of course. Maybe I'll see you at ASHA one day.
Absolutely. And of course, if we can ever...
but yeah.
Yes. And if we can ever be a support to your patients, don't hesitate to reach out. We're happy to help however we can.
Thank you so much. It's so great to see you guys in person.
You too. Thank you. You have a great night.
Thanks so much. Bye-bye.
Take care. Bye-bye.